Welcome back to Beyond the Stethoscope, the podcast for general practitioners. For all of you GPs and registrars out there, especially those gearing up for fellowship exams, you're definitely in the right place.
And today we're diving deep into a topic that's just absolutely crucial for general practice, chronic kidney disease,
Yeah.
CKD. We're using the chapter you shared as our guide, and honestly, this is stuff you'll be using day in, day out.
Absolutely. It's not some, rare bird we barely see. Think about this statistic. Roughly 1 in 10 adult patients walking through your clinic doors right here in Australia actually has CKD.
Mm,
And the real kicker, the vast majority, they have absolutely no idea. It's like this silent current running underneath everything we do in practice.
that's spot on. The
Mhm.
chapter really hammers home how CKD is a master of disguise.
Mm.
The early stages, the symptoms are just so subtle, maybe just a bit of fatigue, feeling a bit odd. They just fly under the radar.
Mm.
It really makes you appreciate how far we've come since way back Richard Bright's observations in 1827 linking dropsy, fluid retention
Yeah.
with kidney problems. That was really the first glimmer.
It's humbling, isn't it, looking back? But here's the positive spin, the empowering bit. The chapter really stresses that early detection and, crucially, the right management can slash the rate of kidney function decline by, well, as much as 50%.
Yeah, it's significant.
And in some cases, you might even see some improvement, some reversibility. That's a huge opportunity for us as GPs to actually make a real difference.
So our mission today really is to thoroughly explore CKD as it's laid out in this chapter. We want to unpack the core definitions, dissect the various causes, and importantly, how they damage the kidneys kind of looking under the hood.
Hmm.
We'll talk diagnoses and lay out the really essential management strategies that are, well, directly relevant to your work in general practice
Yeah.
and, of course, for the exams. The aim is practical, exam-ready knowledge, but without, completely burying you in detail.
Okay, let's get straight into it then. The definition of CKD itself, it's changed a bit over time, hasn't it? It's not just about one single number anymore.
Precisely. Yeah, the definition has definitely evolved, particularly with the introduction of eGFR thresholds. So currently, the diagnostic criteria for CKD, they really hinge on two main things. First is the estimated glomerular filtration rate, or eGFR. That's basically our measure of how well the kidneys are filtering waste, being less than 60 millimN per 1.73 square meters.
Right, the under 60 mark.
Yes, under 60. And crucially, this needs to be the case for at least 3 months. And it's important to note, this can be with or without any other obvious signs of kidney damage.
And that or is really important, yeah. It means CKD can exist even if the eGFR reading looks, well, fairly normal.
Absolutely. That's the second part of the definition. Having evidence of actual kidney damage for at least 3 months, and this holds true even if the GFR itself isn't significantly reduced.
Okay, so what counts as evidence of damage then?
Well, it can take several forms. We're talking things like albuminuria, that's protein leaking into the urine, a really key indicator of kidney stress.
Hmm.
Then there's hematuria, so blood in the urine, but only after we've, properly ruled out any straightforward urological causes.
Sure, like an infection or something.
Exactly.
Yeah.
We also look for structural abnormalities that might pop up on imaging think cysts or scarring you might see on an ultrasound, or even pathological changes. Things identified if a kidney biopsy is done, although that's less common initially.
So just to be clear, a single low eGFR reading, or maybe just one urine test showing a bit of protein that's not enough to actually pin the CKD label on someone straight away.
That's a really critical point for us in general practice. The chapter makes it very clear. You must repeat both low eGFR results and high albumin creatinine ratio, or ACR, results after a 3-month interval. That's how we confirm the issue is genuinely chronic, not just some, temporary blip.
Got it. Persistence over time. That makes sense. Now, you mentioned the sheer scale of CKD earlier. It's pretty widespread, isn't it?
Oh, it really is. As we touched on, about 10% of adult patients in Australian general practice have CKD. But if you zoom out, look globally, at least 95 people per million worldwide need treatment for end-stage kidney disease, ESKD, every single year. That's
Yeah.
a huge burden on healthcare systems, yes, but more importantly, on people's lives.
It really puts the impact into perspective. And there was a particularly sobering statistic in the chapter about the age of some ESKD patients.
Yes, and this is a real eye-opener, I think. Two-thirds of those being treated for ESKD are actually under the age of 60.
Wow, two-thirds under 60.
Yeah, it really drives home that CKD isn't just something that affects older people. It's something we need to be vigilant about across, well, a much broader age range in our clinics.
Definitely a good reminder not to just file kidney problems under elderly. Okay, let's dive into the engine room, so to speak, the key causes of CKD. The chapter lays out a kind of hierarchy of the main culprits.
It does. And for us as GPs, it's not just about knowing the names, right? It's about understanding the underlying pathophysiology, how these conditions actually damage the kidneys, at a cellular level, functional level.
Right. The how.
Exactly. So the most common cause of ESKD in Australia,
hmm
accounting for about 35% of cases overall, is diabetes mellitus.
That's a massive chunk. So what's the kind of step-by-step of how high blood sugar actually leads to kidney damage? What's happening inside?
Okay, so in diabetic nephropathy, it's the chronic hyperglycemia, persistently high blood sugar,
Mm.
that kicks off this whole damaging cascade within the glomeruli, the kidney's little filtering units.
hmm
The high glucose causes a thickening of the glomerular basement membrane. That's a really crucial part of the filter's structure.
hmm
And it also leads to an expansion of these mesangial cells, which provide support within the glomerulus. Over time, these changes, they just make the filtration less efficient. Protein starts leaking into the urine, and ultimately kidney function declines. You can almost think of it like sugar sort of gumming up the delicate machinery of the kidney.
Right, a direct attack by the sugar on the filters. Okay, so what's next on the list of major causes?
Glomerulonephritis. That accounts for roughly 25% of overall CKD cases. Now, this is a pretty broad category. It covers various inflammatory conditions that mainly target the glomeruli.
Okay.
And the chapter specifically calls out IgA nephropathy as the most common type of nephritis leading to kidney failure right here in Australia.
IgA nephropathy. Right, that involves IgA antibodies building up in the glomeruli. What's the chain reaction after that deposition?
Exactly. So in IgA nephropathy, these immune complexes containing IgA, they deposit within the glomeruli. This then triggers an inflammatory response. And over time, this chronic low-grade inflammation leads to scarring, fibrosis within the glomeruli.
Oh.
And that progressively impairs their ability to filter waste. It's like, having persistent inflammation anywhere in the body. Eventually, it causes damage and loss of function.
Okay, so inflammation driven by these antibody deposits is the key mechanism there. Hypertension, high blood pressure is another big one, about 13%. How does that constant high pressure wear down the kidneys?
Well, chronic hypertension puts just immense sustained stress on the tiny blood vessels inside the kidneys. This leads to a condition called nephrosclerosis.
Ah.
Essentially, the walls of the arterioles, the tiny arteries, they thicken up, and the glomeruli themselves get scarred. That's glomerulosclerosis.
Right.
These changes reduce blood flow to the kidneys, and as a result, their capacity to filter waste effectively. Imagine like trying to force water through pipes that are constantly squeezed tight and getting clogged up.
Yeah, a gradual wearing down of the kidney's plumbing due to pressure.
Okay.
Polycystic kidney disease is also mentioned as a significant cause.
Yes, polycystic kidney disease, PKD, that's responsible for about 8% of CKD cases. This one's genetic. Basically, numerous fluid-filled cysts develop inside the kidneys. And these cysts, they just gradually get bigger over time, physically compressing and eventually replacing the healthy, working kidney tissue. This leads to a progressive decline in function.
Hmm.
It's like having more and more space-occupying lesions just crowding out the normal kidney.
So it's the physical presence, the expansion of the cysts that stops the kidney working properly. Reflux nephropathy is another one, also around 8%. That's where urine flows backwards towards the kidneys, isn't it? Usually a valve issue between the bladder and ureters.
Precisely. Vesicoureteral reflux. It often starts in childhood, and it allows urine to flow backwards retrograde from the bladder up the ureters, sometimes right into the kidneys. This backflow makes recurrent urinary tract infections much more likely. And the crucial part here is that these repeated infections cause scarring of the renal parenchyma, the actual functional tissue of the kidney. It's this repeated insult, the infection, and the resulting scar tissue that eventually compromises kidney function over time.
So repeated infections and scarring are the drivers there. Okay. The chapter also lists vascular causes more broadly. What are the key issues under that heading?
Yes, so vascular problems like atherosclerosis, hardening of the arteries, including stenosis, which is narrowing, of the renal arteries themselves can definitely contribute to CKD.
Okay.
Atherosclerosis in the renal arteries reduces blood flow to the kidneys. This leads to something called ischemic nephropathy, where the kidney tissue basically isn't getting enough oxygen and nutrients, impairing its function. Think of it like a restricted fuel supply starving the kidney engine.
Makes perfect sense. Cutting the blood supply is bound to hurt performance. What about blockages, obstructions in the urinary tract?
Right. Obstructive nephropathy. This can happen due to bilateral ureteric obstruction. So blockages in both tubes leading from the kidneys to the bladder or bladder outflow obstruction, which we often see caused by, say, prostatic enlargement in men.
Mm-hmm.
Any chronic obstruction leads to a buildup of pressure within the kidneys. This causes hydronephrosis, that swelling of the kidneys because urine can't drain properly. And eventually, this back pressure damages the kidney tissue itself, like, putting a dam in a river. The water backs up and
Yeah.
causes damage upstream.
So that persistent back pressure is the damaging force in obstructive nephropathy. Drugs are also flagged as a potential cause.
Absolutely. Certain medications can be directly nephrotoxic, basically poisonous to kidney cells.
Okay.
The chapter specifically highlights NSAIDs, the non-steroidal anti-inflammatories, which are obviously very common.
Yeah, very common.
And it mentions analgesic nephropathy specifically. This is a type of tubulointerstitial damage that results from long-term excessive use of certain combination painkillers, often older ones containing things like phenacetin or even high doses of aspirin and paracetamol combinations over time.
A really important reminder for us to always think about potential kidney side effects when prescribing, especially long term. The list of causes keeps going. It covers a really wide range.
It really does. You've got systemic autoimmune diseases like lupus, other connective tissue disorders. These can cause immune-mediated glomerulonephritis, where the body's own immune system mistakenly attacks the kidney.
Right.
Then there are vasculitides, like polyarteritis nodosa, pandan. These involve inflammation of blood vessels throughout the body, including those in the kidneys, and that leads to glomerular damage and reduced blood flow.
So, conditions where the body's defenses turn inwards against the kidneys? Gout is also on that list.
Yes, with gout, it's the deposition of urate crystals within the renal interstitium. That's the tissue between the kidney tubules that can lead to chronic kidney disease, sometimes called urate nephropathy. This chronic inflammation and the physical presence of crystals gradually impair function.
And we shouldn't forget things like amyloidosis and multiple myeloma.
Correct. Amyloidosis involves abnormal proteins, amyloid, depositing in organs, including the kidneys, just disrupting their normal structure and function. Multiple myeloma, the plasma cell cancer, can damage kidneys in several ways. Direct toxicity from the light chains the cancer cells produce, causing hypercalcemia, other metabolic issues. It's quite complex.
And finally, hypercalcemia itself, high calcium, regardless of the cause, can damage kidneys too.
That's right. Prolonged high calcium levels can lead to nephrocalcinosis, calcium deposits forming within the kidney tissue. This causes inflammation, scarring, and ultimately impaired function. So as you can see, CKD has this incredibly diverse range of potential causes,
Absolutely.
which is why, a really thorough history and investigation are so crucial to try and pinpoint the specific reason in each patient we see.
Definitely. And understanding all these different ways the kidneys can be damaged really hammers home the importance of early detection, which we mentioned right at the start.
Exactly.
Yeah.
Because if we can catch the underlying cause early on, we have a much better shot at putting interventions in place that can slow down, maybe even halt, the progression of the damage. And as the chapter pointed out, sometimes in specific cases, there's even potential for a degree of reversibility.
So given this, well, quite long list of potential causes, what are the key risk factors that should really heighten our suspicion? Who should we be particularly looking out for in our patient population?
The chapter helpfully breaks these down into non-modifiable and modifiable risks.
Yeah.
So on the non-modifiable side, age is a big one. Risk climbs over 60. A family history of CKD definitely increases susceptibility.
Right.
It's also really crucial to remember that Aboriginal and Torres Strait Islander peoples have a significantly higher risk, and this risk starts to increase from a younger age, generally considered above 30 years.
Okay.
And also, any past history of acute kidney injury, AKI, even if it seemed to resolve completely, is another non-modifiable risk factor to keep in mind.
And on the modifiable side, these are the things we're often tackling anyway in general practice, right? The lifestyle and chronic disease factors.
Precisely. Diabetes and hypertension are arguably the two most significant modifiable risk factors. Smoking definitely has a detrimental effect on kidney health, as does obesity, usually defined as a BMI of 30 or more. These are all areas where our proactive interventions as GPs can genuinely make a meaningful difference in reducing CKD risk and slowing progression.
It's also vital, isn't it, to remember that CKD isn't just a kidney issue in isolation. It massively increases cardiovascular risk.
Oh, absolutely. The presence of CKD independently just elevates the risk of developing cardiovascular diseases, like heart attacks, strokes, peripheral vascular disease. So When we're managing CKD, we are inherently, or should be, also focused on aggressively managing our patient's overall cardiovascular risk profile. It's intrinsically linked.
Okay. Now, let's talk about how CKD actually shows up, how it manifests. The chapter talks about its often silent progression and how uremic symptoms are frequently nonspecific.
Yes, this insidious development is one of the biggest challenges in catching CKD early. Uremic symptoms, the ones caused by waste products building up as kidney function declines, they tend to be quite vague, easily mistaken for other common things, especially early on.
Like just feeling tired or run down.
Exactly. The chapter really emphasizes that these symptoms often don't become truly obvious until the creatinine clearance is significantly down, often less than 20% of what's considered normal.
Wow, less than 20%. So by the time a patient is feeling symptoms directly related to their kidneys, the disease is already quite advanced. What are some of these uremic symptoms that should, raise a red flag for us?
Well, common ones include just a general sense of malaise, feeling unwell, loss of appetite, anorexia, nausea, sometimes vomiting, persistent tiredness or lethargy is a big one.
Mm,
Patients might also notice nocturia, having to get up more often at night to wee. Restless leg syndrome can be really troublesome, especially when the eGFR drops below 15 or so. Pruritus, itchy skin is common, and dyspnea, shortness of breath.
okay.
The chapter even mentions a later sign, that sort of sallow, yellowish, almost lemon tinge appearance of the skin. That comes from a combination of anemia and the buildup of certain waste pigments.
That lemon tinge sounds like a classic textbook sign, but probably indicates quite advanced failure, right?
Yes, definitely a late sign. So in our day-to-day practice, what clinical associations or existing conditions should make us think, okay, I need to actively consider CKD here?
The chapter gives a really handy checklist. We should definitely be screening and monitoring for CKD in all patients with established diabetes, hypertension, and any form of known cardiovascular disease.
Right, the big three.
Yeah. Also, a history of severe gout, any known urinary tract abnormality like reflux, recurrent stones, bladder outlet issues, or a past episode of AKI or family history of kidney failure, all of those should significantly raise our suspicion levels.
And what about specific presenting symptoms?
Yeah.
Things that should make us investigate for CKD, even if someone doesn't have those known risk factors.
Okay, so unexplained, persistent poor health generally, new onset hypertension, or maybe blood pressure that was controlled and suddenly becomes difficult to manage, anemia without an obvious cause like iron deficiency,
Mm-hmm.
persistent unexplained itching, so pruritus,
Mm-hmm.
evidence of hyperparathyroidism, which we might pick up incidentally on bloods, unexplained pericarditis, any new or changing urinary tract symptoms like persistent protein or blood in the urine, unexplained swelling or edema, new nocturia, loin pain, or symptoms suggesting prostate issues in older men.
Okay, that's quite a list.
It is, and even certain neurological disturbances, unexplained confusion, maybe coma in really severe cases, peripheral neuropathy, or even new onset seizures, sometimes these can be a sign of advanced kidney disease and the buildup of uremic toxins.
That's an incredibly broad range of potential ways it can present. It really underlines how CKD can be such a masquerader in our clinics. So what might we actually pick up on physical examination that points towards CKD?
Well, a careful general look can give clues. You might notice that sallow complexion, the yellowish-brownish pigmentation, the skin might feel dry, the patient might report itching. Given the cardiovascular link, always check blood pressure and heart rate.
Of course.
Because of anemia and potential acidosis, their respiratory rate and pulse might be up. Other things to look for: easy bruising, maybe that characteristic uremic fetor on the breath, reduced alertness in more advanced cases, signs of pericarditis, or evidence of peripheral neuropathy when you examine them neurologically.
Abdominal palpation, especially feeling for the kidneys, assessing for enlargement or tenderness is important. And in older men, a rectal exam to check the prostate is often needed. Don't forget ophthalmoscopy. Either looking in the back of the eye might show hypertensive or diabetic changes, giving you indirect evidence of systemic disease.
Mm-hmm.
And of course, a simple urine dipstick test can give initial clues: glucose, blood, protein.
And if we do see protein on the dipstick, the next logical step is usually getting a better handle on how much with the albumin creatinine ratio, the ACR.
Exactly. The chapter gives us clear definitions for interpreting the ACR. So normal albuminuria, normal is generally less than 2.5 millimole for men, less than 3.5 for women.
Okay.
Microalbuminuria, which is that early stage of increased leakage, is in the range of 2.5 to 25 for men and 3.5 to 35 for women.
Right, microalbuminuria.
And then macroalbuminuria, if that's persistently present, it's a strong sign of more significant kidney damage, often moderate to severe CKD. That's an ACR over 25 in men, over 35 in women. Well, sometimes you might need a 24-hour urine collection for protein. The ACR is generally the go-to, more convenient method for routine checks and monitoring in GP land.
Okay, so what are the key initial tests we should think about ordering in general practice when we suspect CKD
Yeah.
based on history, exam, or that initial urine test?
Well, the urine dipstick is often step one, practically, but as the chapter notes, it has limitations, sensitivity, specificity, especially for lower levels of albumin. Any positive protein result really needs a follow-up ACR to quantify it properly.
Right.
We should also think about a urine microculture, just to rule out a UTI that might be muddying the waters. Basic bloods like ESR and a full blood count, FBE, help check for anemia, which is common. Then the core kidney function tests, plasma urea, plasma creatinine, and crucially, calculating the eGFR using the standard CKP-EPI formula. That's our main measure now. We also need to routinely check plasma electrolytes, sodium, potassium, chloride, bicarbonate, calcium, and phosphate, because kidney impairment throws these off.
And there are other, maybe more specific blood or urine tests we might consider depending on the clinical picture if we suspect a particular underlying cause.
Yes, absolutely. Depending on the context, if you're suspicious of certain causes, you might also measure serum magnesium or urate. Checking glucose and lipids is vital because of that strong link between CKD, metabolic issues, and cardiovascular risk.
Yeah.
If the patient's on drugs that affect kidney function or whose levels are affected by kidney function, checking drug levels might be needed. Cardiac tests like an ECG might be indicated. If you're thinking myeloma, maybe protein electrophoresis if you suspect lupus or vasculitis, ANA or ANCA tests. To really nail down the underlying cause sometimes requires imaging, usually starting with an ultrasound of the urinary tract, maybe more specialized immunological tests. And in some complex cases, a kidney biopsy might be needed, but that's generally something a nephrologist assesses and arranges.
And the chapter also mentions some typical biochemical changes we see in the bloods as CKD progresses.
That's right. As kidney function declines, you typically see a progressive rise in serum potassium, phosphate, creatinine, and urea. That's because the kidneys just aren't excreting these waste products effectively.
Makes sense.
Urinary protein excretion goes up, reflected in that rising ACR. And because the kidneys are key for acid-base balance, you often see serum bicarbonate levels drop, hydrogen ions increase, leading to metabolic acidosis, especially in the more advanced stages.
Okay. So once we've established a diagnosis of CKD, how should we be monitoring these patients effectively in general practice? How do we track progression and response to treatment?
The eGFR, the estimated glomerular filtration rate, calculated using that CKP-EPI formula, is the absolute cornerstone for monitoring progression.
Right. That's the key number to watch.
It really is. And the chapter stresses that an eGFR consistently below 60, even though it's more common as people get older, is independently linked to a significantly higher risk of bad outcomes. Progression of the kidney disease itself, yes, but also cardiovascular events.
Mm-hmm.
And while some people might remember that old rough guide of, eGFR be maybe 140 minus age,
Yeah, I remember that from somewhere.
it's really crucial to rely on the lab-calculated eGFR using the proper CKP-EPI formula for accurate assessment and tracking over time.
Okay, so stick to the formal calculation for clinical decisions. Now, an area that is just so critical for us as GPs in looking after CKD patients is prescribing. Safe and effective medication use.
Absolutely paramount. Drug prescribing in CKD can be, well, a minefield if we're not careful.
Yeah.
The chapter lists drugs that can directly harm the kidneys,
Uh-huh.
the classic nephrotoxins like gentamicin, vancomycin, but also very commonly used drugs like NSAIDs and COX-2 inhibitors.
Yeah.
Also other antibiotics like aminoglycosides, some cephalosporins, tetracyclines, lithium, colchicine. We always need to weigh the benefits against those potential renal risks.
And we need to be particularly wary of the infamous triple whammy, don't we? That's a combination to actively avoid, if possible.
Yes, the chapter specifically flags it.
Oh.
Using an NSAI or COX-2 inhibitor together with an ACE inhibitor or an ARB and a diuretic. That combination, even in someone with seemingly stable kidney function, significantly bumps up the risk of causing an iatrogenic acute kidney injury.
Right, so NSAID, COX-2 plus ACIOB plus diuretics danger.
Pretty much. And even diuretics on their own need careful use in CKD as they can sometimes worsen electrolyte imbalances or cause dehydration.
Okay. What about drugs that might not directly damage the kidneys but can lead to dangerous electrolyte issues like hyperkalemia, hypotassium?
Yeah, several common drugs can push potassium levels up, especially in CKD patients. NSAIDs and COX-2s again, ACE inhibitors and ARBs, potassium-sparing diuretics like spironolactone, aldactone, or amiloride. the antibiotic trimethoprim, often in cotrimoxazole, even digoxin. We need to be really mindful and monitor potassium, especially when starting or changing doses of these.
And beyond direct kidney damage or high potassium, are there other drug categories where we need extra vigilance due to increased risk of side effects in CKD?
Yes, quite a few actually. Allopurinol for gout carries a risk of hypersensitivity reactions that can affect kidneys and liver. Statins, generally good for cardiovascular risk, can occasionally cause muscle problems, and that risk might be slightly higher in CKD, especially if combined with imfibrozil. The chapter advises caution, often avoiding that specific combination.
Okay, statin plus gemfibrozil, caution in CKD.
Yeah. Some beta-lactam antibiotics can rarely cause interstitial nephritis. Low molecular weight heparin, LMWH, increases bleeding risk, already a concern sometimes in CKD. Aspirin and NSAIDs increase GI bleed risk. Even PPIs like omeprazole have been linked, in some studies, to interstitial nephritis with long-term use.
Wow, it's a really broad list of potential pitfalls. And then there are the drugs that just build up to toxic levels because the kidneys aren't clearing them properly.
This is such a critical area. The chapter has a really useful table outlining drugs with a high risk of accumulation and the potential problems. For instance, acyclovir can cause confusion, encephalopathy. Cotrimoxazole, increased risk of severe skin reactions like Stevens-Johnson.
Right.
Long-term metronidazole, maybe peripheral neuropathy. High-dose IV penicillin or quinolone antibiotics, risk of seizures. Metformin, risk of lactic acidosis if kidney function is significantly impaired. Sulfonylureas, prolonged hypo risk.
So insulin doses often need adjusting down, too.
Absolutely. Insulin needs careful adjustment to avoid hypos as kidney function declines. Beta blockers like atenolol can cause excessive bradycardia or heart block. Digoxin toxicity nausea, bradycardia is much more common. Sotalol, risk of serious arrhythmias. Even things like codeine can cause confusion, acute brain syndrome in CKD. And then drugs like methotrexate, lithium, relisate, they also need careful dose adjustment and monitoring due to risks like liver dysfunction, bone marrow suppression, tremor, confusion, thyroid issues. That table is really an essential checklist before prescribing anything for a patient with known CKD.
It absolutely hammers home the need to always think kidneys when writing a script.
Hmm.
Okay, let's shift gear to the overall management of CKD in general practice. It really sounds like it needs to be a team effort.
Oh, completely. The main goals are really twofold. First, slow down the progression of the kidney disease itself. Second, aggressively manage those sky-high cardiovascular risk factors that go hand in hand with CKD. And of course, identifying and, if possible, correcting the underlying cause is vital. The chapter rightly stresses that optimal CKD care is multidisciplinary. Nephrologists, dietitians, other allied health are often involved.
But the GP's role is central.
Absolutely central and ongoing, providing that continuous care, the monitoring, the crucial psychosocial support, including screening for depression, which is more common. The main therapeutic targets boil down to controlling blood pressure, reducing protein in the urine, proteinuria, and minimizing overall cardiovascular risk. And developing an advanced care plan, considering patient wishes as function potentially declines, is a key part of holistic care.
So practically speaking, what does optimal CKD treatment look like day to day in our practice?
Okay, it means regular, comprehensive reviews.
Yeah.
Good blood pressure control, the chapter highlights this as possibly the most effective thing to slow progression. Maintaining fluid and electrolyte balance. Promptly treating any intercurrent illnesses because they can really destabilize kidney function.
Yeah, infections and things.
Exactly. Judicious drug use, as we've hammered home, avoiding nephrotoxins, being careful with potassium-sparing diuretics unless closely monitored. Quickly tackling complications like saltwater depletion or UTIs. Dietary management is key, often a tailored low-protein, low-sodium, sometimes low-potassium diet, usually guided by a dietitian. Patients need strong advice to avoid toxins, nicotine, excessive alcohol, caffeine, managing anemia, actively iron if needed, erythropoietin, EPO, in more severe cases, usually specialist guided. Again, that proactive attention to advanced care planning.
And are there specific target ranges we should be aiming for with all these different parameters?
Yes, the chapter gives some helpful targets. Blood pressure, generally 14E90, but tighter. Third, the 80, if there's significant proteinuria, albuminuria, or diabetes.
Okay, tighter target for protein diabetes.
Exactly. Total cholesterol, aim under 4.0 millimole, LDL under 2.5 for diabetes. Pre-meal glucose, 4.4, 6.8. HbA1c, 8.7%. Hemoglobin, aim for 101 and 15 GL. Serum potassium, keep EP 6.0 millimole.
Yep.
Aim for a healthy BMI 2025. Serum albumin, ideally 35 GL. Try to get at least a 50% reduction in albuminuria if possible. For acidosis, in bicarbonate 22 millimol, phosphate 1.75 millimol, and of course no smoking, limited alcohol, max 2 standard drinks day.
Those are really clear, actionable targets. Let's dig a bit deeper into some key areas, starting with blood pressure control, which is often tricky in CKD.
Right. A cornerstone is dietary salt restriction, though it needs to be individualized. Drug-wise, while no class is totally out, we need to be careful with kidney-excreted drugs like ACE inhibitors, Adderall, sotalol doses may need adjusting based on eGFR.
Right.
ACE inhibitors and ARBs are generally first line, especially with proteinuria or diabetes. But crucially, don't use them together, higher risk of bad renal outcomes, hyperkalemia. And be cautious starting them if you suspect renal artery stenosis.
Okay, AC SARBs first line, but not combined, and watch for stenosis.
Exactly. Loop diuretics like furosemide are often needed for hypertension and fluid overload, sometimes needing higher doses as function drops. Non-dihydropyridine calcium channel blockers, beta blockers, can be useful add-ons. The goal is target BP with the fewest drugs at lowest effective doses, closely monitoring kidney function and electrolytes.
And managing anemia, which is so common.
First step is always rule out other causes of infection, iron deficiency. If iron deficient, replete with oral or IV iron. For the CKD-related anemia, erythropoietin-stimulating agents, ESAs, can boost red cell production if HB drops below about 100 GL.
But usually guided by specialists.
Yes, ESA use and target HB are typically nephrologist-guided, as pushing HB too high has risks. Try to avoid blood transfusions if possible because of sensitization risk, especially for potential transplant candidates and transfusion reactions.
Okay. What about hyperphosphatemia and hyperkalemia, those common, potentially dangerous electrolyte issues? How do we manage those, often with specialist input?
Hyperphosphatemia, high phosphate, is mainly managed with dietary phosphate restriction, sometimes means moderating protein, and phosphate binders. Things like calcium carbonate or calcium acetate tablets taken with meals to stop phosphate being absorbed.
Right. Binders with food.
Hyperkalemia, high potassium, especially if it gets over 6.0 or 6.5, is a medical emergency due to cardiac risk. Initial steps: stop offending drugs, ACEs, ARBs, potassium sparers, restrict dietary potassium.
And acute treatments.
Acute treatments can include nebulized salbutamol, shifts K plus into cells, IV insulin and dextrose, also shifts K plus in, IV calcium gluconate, protects the heart, doesn't lower K plus. Oral resins like rosonium A help excrete potassium via the bowel. In severe cases, dialysis might be needed urgently.
Speaking of dialysis, when does that become necessary for our patients?
Dialysis becomes the necessary renal replacement therapy when conservative management just isn't cutting it anymore. Severe fluid overload, refractory high potassium or acidosis, really symptomatic uremia. It's a huge life change. Hemodialysis is most common, usually 3 times a week in a center, filtering blood via a machine. Peritoneal dialysis is another option, done at home, usually daily, using the tummy lining as the filter.
And the AV fistula?
Yes. For hemodialysis, the preferred access is usually an arteriovenous AV fistula, surgically made in the arm. It provides good blood flow, absolutely crucial. Never take BP or put IV lines in an arm with a working fistula. You can damage it.
Got it. No procedures on the fistula arm. And kidney transplantation is the other main option for end-stage disease.
Yes, where it's not contraindicated, things like active cancer, severe heart disease, active infection might rule it out. Transplantation is generally the preferred treatment. It offers better quality of life and survival than long-term dialysis.
But donor shortage is an issue.
Huge issue with deceased donors. Living donation depends on finding a suitable, willing donor. After transplant, rejection and infection are major worries, especially early on. Patients need lifelong immunosuppressant drugs, absolutely vital. They never stop taking them.
Lifelong immunosuppression.
Yes, and long-term, there's an increased risk of certain cancers due to that chronic immunosuppression, skin cancers, lymphomas, some others.
Okay. The chapter also briefly mentions specific points for CKD in kids and the elderly. Any key differences we should know?
In kids, CKD is less common, thankfully. Causes are often different: congenital kidney urinary tract anomalies, chronic glomerular nephritis, reflux obstruction. Early detection via antenatal scans and investigating UTIs in kids is important. Dialysis and transplants in very young children raise complex ethical and practical issues.
Right. And in the elderly?
In older adults, an eGFR 60 is quite common, often part of aging. But importantly, it still carries increased risk, especially cardiovascular risk. So management needs to be highly individualized. You have to weigh benefits versus risks of interventions, consider quality of life, functional status, patient preference. Sometimes more conservative management is appropriate for frail individuals.
So a very tailored, holistic approach, especially at the age extremes. Now, a really crucial question for us GPs. When should we refer a patient with CKD to a nephrologist? What are the key triggers?
The chapter gives clear criteria. Consider referral if you see glomerular hematuria, proven on microscopy, an eGFR persistently below 30, stage 4 or 5 CKD, a rapid decline in kidney function, say, a sustained drop 5 in a linear.
Okay, eGFR 30 or dropping fast.
Yes. Also, significant proteinuria, 1G 24 hours, or ACR persistently 30 millimere. The combination of glomerular hematuria with macroalbuminuria, kidney impairment plus poorly controlled hypertension despite multiple drugs, and patients with diabetes who have an eGFR 60 or significant albuminuria proteinuria.
Right.
Now, experienced GPs might manage some less complex earlier stage cases without immediate referral, but it's always good to have a low threshold for seeking advice. And critically, any patient with a rapidly declining eGFR and/or signs suggesting acute nephritis, like oliguria, hematuria, edema, sudden hypertension, that's a medical emergency needing urgent assessment.
Those are really clear, practical referral guidelines. Finally, patient education and good resources are so important for managing a chronic condition like CKD. What can we point our patients towards?
Well, the chapter mentions patient info sheets, like those from Murtaugh's Patient Education. It also highlights some excellent online resources for both us and patients. Kidney Health Australia's website, kidney.org.au, is fantastic loads of info.
Yeah, that's a great one.
The Renal Drug Reference Guide is invaluable for safe prescribing. For Aboriginal and Torres Strait Islander patients, the NTCHO website might have culturally appropriate resources. The Australian Cardiovascular Risk Calculator helps patients understand their overall risk, and the 98 guidelines from the UK are very comprehensive. We should really familiarize ourselves with these so we can guide patients effectively.
Fantastic. Well, that's been a truly comprehensive deep dive into chronic kidney disease based on the chapter. Let's just quickly recap some absolute key takeaways for our busy GPs and registrars, especially with exams in mind.
Absolutely. Okay, key points. Remember, CKD is common and often silent. Many patients won't know they have it. Early detection and the right management can change the trajectory. Understand the main causes and the pathophysiology. Be incredibly careful with prescribing of the nephrotoxic drugs, the ones needing dose adjustment, the ones causing electrolyte issues like hyperkalemia, and know the clear referral guidelines when to get the nephrologist involved.
And perhaps most crucially, remember our vital role as GPs. Identifying at-risk patients, starting investigations, managing the early stages, coordinating care, providing that ongoing support and education. This detailed knowledge isn't just good patient care, it's absolutely crucial for fellowship exams.
Definitely. So here's a final thought, something to mull over. Given that huge cardiovascular risk linked to CKD, how proactively, how systematically are we really screening our at-risk patients in daily practice? And are we truly optimizing their overall management? Looking beyond just BP and glucose. It's something worth reflecting on constantly.
A very important point for reflection indeed. We really encourage you to explore those online resources for more learning and to really integrate this knowledge into your everyday patient care. Thank you so much for joining us for this deep dive on Beyond the Stethoscope, the podcast for general practitioners. We look forward to catching you on the next one.